Hello, good morning everyone. This is a clinical case presentation. I hope you people are all exposed during the second MBBS clinical cases presentation and everything. Bedside presentation is different when compared to online presentation. I hope you understand this presentation and most of the things you know already, because the presentation, clinical presentation, uh, is common in most of the subjects like medicine, surgery, pediatrics. uh, so coming to the case presentation, generally you go with the name, age, sex, race, gender, and presenting complaints, and history of present illness and past history, and general physical examination, all these things. But I want to concentrate on the only the examination part, because most of the things I hope you know history and everything. And in case of GIT physical examination, you want to examine the abdomen. So the presenting complaints is usually the complaints related to the abdomen, like vomiting, nausea, jaundice, abdominal pain, abdominal distension, and GI bleed, and melena, and any organomegaly, like abdominal distension, uh, and other features. These things point towards the GI examination for the child. And coming back to the physical examination, so now I'm starting basically the examination part. I'm not going in details of the history. Initially we will do about the abdominal examination, and later on we go with the case presentation, and how you present the case basically. So basically, before knowing the abdominal examination, first thing, GIT system starts from the mouth and ends at rectum. And in case of abdominal examination, you have to know few things before abdominal examination. First, what are the regions and surface markings over the abdomen? And what is inspection, palpation, percussion, auscultation, and examination of the external genitalia and rectal examination. So the complete abdominal examination involves both genital examination and rectal examination also, but we do less commonly, only in cases we will do the rectal examination and other examinations. So regions and surface markings. So abdomen can be divided into 9 regions, or based on 4 as per anatomy. So I am going back to anatomy once. uh, so regions and surface markings. So why you need to know the regions and surface markings? Because if you know the regions and surface markings, you can able to know the which organ is located where, and what is the structure, and what will be the cause in that quadrant, if at all pain and other things are there. So those things might help you to know the anatomy. So in case of 4 quadrant structure, the line passing through the sagittal and transumbilical plane, you divide the abdomen into 4 quadrants, and right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant basically. So in case of right upper quadrant, you have the right diaphragm and liver and coastal margin, gallbladder. And in case of the left upper region, you have the spleen and stomach and pancreas sometimes. And in case of right lower quadrant, you have appendix, cecum, colon, and there is a point, McBurney's point, inguinal ligament about the hernial orifices. And in case of left, there is a descending colon and sigmoid colon. So basically, we divide the abdomen into 9 quadrants for easy understanding. This is for better understanding. So we divide the abdomen by mid-clavicular planes, and horizontal planes by subcostal plane and intertubercular plane. So based on these planes, we divide the abdomen into 9 quadrants. The center green part, what you see is the epigastric region, and right side is the right hypochondrium, and left side is the left hypochondrium. That is subcoastal region. That is coastal margin, where the coastal margin is felt. That is called right hypochondrium and left hypochondrium. And the center one is the umbilical region, and lateral parts are called right flank and left flank. And in case of the middle, is called as pubic region or suprapubic region, and right iliac fossa and left iliac fossa, mostly right groin and left groin. So these are the 9 surface markings and 9 regions based on 2 midclavicular planes and the subcoastal and intertubercular plane. So before examination, so ensure that bladder is empty and patient is comfort and arms at side or crossed over the chest for examination of the abdomen, and ask the patient to point to any painful areas and examine the painful areas at last. See, like suppose if the patient is having the pain in the left groin or left iliac fossa, so you have to examine from the right iliac fossa and go last to the left iliac fossa. And similarly, if the patient is having the pain in the right iliac fossa, you have to examine from the left iliac fossa and come back to the right iliac fossa in anti-clockwise direction. And warm hands and stethoscope. So inspection. So in inspection, what do you find out the abdomen is what is the shape of the abdomen, whether the abdomen is scaphoid or normal or distended. Protuberant abdomen. So protuberant abdomen you see in case of pot belly, in case of rickets, and abdominal distension because of ascites or other things. In case of scaphoid abdomen, you see in case of congenital diaphragmatic hernia. Flanks will be normal without any fullness, but in case of flanks are full, you have to suspect whether is any uh, fluid accumulation or other things. And umbilicus, so umbilicus, in case of inspection, you have to note down the like uh, umbilicus, whether the umbilicus is central, what is the shape of the umbilicus, how it is inverted or everted, uh, any displacement of the umbilicus is not in the midline position, any serious discharges from the umbilicus, any discharge from the umbilicus, you have to note down all these points. And movements of the abdomen, so all the 4 quadrants or all the basically 4 quadrants, all the 4 quadrants are moving equally or not, is there any decreased movement is there or not. And veins of the abdominal one, so how are the veins, are there any visible veins are there, and any gross dilatation of the abdominal wall veins is seen, like caput say. And any peristaltic movements you see in case of pyloric stenosis and intestinal obstruction. And how is the skin over the abdomen, like any scars, sinuses, and swellings. Hmm? And in case and exam and see for the any hernial sites, like any swelling in hernial sites or not, say hernial sites are intact or not. And external genitalia, is there any ambiguous genitalia, other things. So all these findings you see in case of inspection. So in case before palpation, so ensure that your hands are warm, because don't touch any patient with your cool hands or some other. So you have to rub your hands and make the hands warm, and then you have to touch. Before palpation, ask the patient whether you can palpate him or not. In case of child, you have to take consent from the mothers, or in case of child is about 12 years, you can ask him directly and you can examine. So take consent first. Stand on the patient's right side, help to position the patient. Ask whether the patient feels any pain before you start, because you have to know if patient feels any pain in any region, because you have to examine that region last. Because if you examine the region that first, and he may not cooperate. Begin with superficial examination and move in a systematic manner through the abdomen quadrants. Repeat palpation deeply. So this is superficial palpation. Why we done superficial palpation is palpation of the abdomen without any pressure, just to know any local rise of temperature, what is the feel of the abdomen, whether abdomen is rigid or not, tenderness, guarding is there or not, any divarication of recti. So superficial palpation to know basically whether the patient is having any pain over the specific region or and local rise of temperature. How is the feel of the abdomen? So this pic shows the superficial examination of the abdomen, and this is deep palpation. So to look for any organ enlargement or abdominal mass or rebound tenderness. See, this is done by conventional method and dipping method. In dipping method, you use two hands and you dip the abdomen and allow the patient to take air, inhale. Okay, this picture is the dipping method, and this is Blumberg sign where you say for rebound tenderness. Initially, you give a pressure over that area and release suddenly. So sudden release of hands will cause the pain, rebound tenderness. Usually seen in peritonitis. So this is Blumberg sign and dipping method. So palpation of specific organs. Coming back to deep palpation, and you have seen that whether to do conventional method or dipping method, and palpation, in deep palpation you have to see for any organ enlargement is there or not. So in case of liver, so in case of abdominal examination or any other point, actually, uh, patient should be in supine position and flex the knee joint. Ask the patient to take deep breaths. Uh, Start palpating in the right iliac fossa. Move hands progressively further up the abdomen and try to feel the liver edge. Check the liver span. So basically, we were examining for the liver. You have to see the what is the edge of the liver, what is the surface, what is the consistency and span. You have to note down all these things based on in liver. You have to see in liver also examination of specific organ also like inspection, palpation, percussion, and all these things come up. So these are the two ways of palpating the liver. Basically, you can take the radial side of your index finger, starting from the right iliac fossa. You can see the either palpate with the radial side of the right iliac fossa. Ask the patient to take deep breaths in, so that deep breaths, enlarged liver can touch your radial surface. So after exhaling again, if you don't touch, you move forward. So that is the method for palpation of the liver. Basically, this is a conventional method. The other method is like you will feel with the tip of your fingers. So, so you see both the pictures. First one is conventional, and second one is by tip of the fingers. Another method, but most commonly we see the radial side of the index finger. We use the radial side of the index finger for the enlargement of liver or any other organ. And this is percussion by tidal percussion, because tidal percussion is done to know the liver span basically, and you percuss from the second intercostal space from the right side of the hemithorax and ask the patient to take this. Where you get a dull note, you consider it as a upper border of the liver basically. So basically, if you know the upper border with the tidal percussion and lower border with palpation, you measure in the mid clavicular line what is the span of the liver. Coming back to spleen examination. So in spleen examination, based on inspection, any abdominal distension or specific decreased movements in the abdomen, and palpation, either bimanual method or hooking method. In case of percussion, use the Tobis sign, CASTELL'S sign, and NIXON'S method. Basically, these are the things used for spleen examination. So in case of bimanual method, first picture, what you see is bimanual examination. You support the with posterior of the rib cage or costal surface, posterior abdominal, posterior left costal surface with the your left hand. You support it and ask the patient to take deep breaths, and you go on palpating from the right iliac fossa across the umbilicus to the uh, left hypochondrium to palpate the spleen if there is any, is there any enlarged spleen is there or not, because spleen grows towards the right iliac fossa, so that we can know the enlargement. This is this first picture is a bimanual bimanual examination, and the other picture side picture is nothing but a hooking method. In hooking method, you hook around the left costal margin and ask the patient to take deep breaths, where you can feel the tip of the spleen, enlarged spleen is there or not. So this is hooking method. There is a Middleton maneuver that is also similar to the hooking method, but you use you you take the right hand for hooking, and keep the left hand in the posterior coastal surfaces for support, and you feel for the spleen enlargement. In case of the hooking method, the patient should stand sorry, the examiner should stand on the left side of the patient and should face the toes of the patient, and you hook the left coastal margin towards you and pull up, so that you can feel for the spleen enlargement. And coming back to percussion, in the percussion you can know the spleen enlargement by these three methods: Trobispace and CASTELL'S method and NIXON'S method. In case of Trobispace, next slide I am going to show the pictures. What are those actually? Nothing to worry. Trobispace is nothing but a triangle border by the sixth rib superiorly and left middle axillary line laterally and left costal margin inferiorly. So normally resonant and dull if splenomegaly. So this top space is normally is resonant, but if there is a spleen enlargement is there, you feel it as dull during percussion. That is top space. Castell's method or Castell sign. So patient in supine position percuss on the left last intercostal space and left anterior axillary line, that is called Castell's point. The Castell point is nothing but in case of in the last intercostal space and left anterior axillary line. So intersection point of the left last intercostal space and the left anterior axillary line is called Castell's point. Normally it is resonant but dull in case of splenomegaly, and I will tell you Nixon method later. And coming back to the pics, so in case of first see, you can see the Trobby space and area to percuss for the Castell sign. So Trobby space is a triangular space, basically horizontal by sixth rib, okay, and borders formed by left anterior axillary line and costal margin. So this triangular space is nothing but this is a Trobby space, and the point of intersection where the last intercostal space and left anterior axillary point is nothing but Castell's point, or where you feel if resonant it's normal, and if you feel dull note it is called uh, splenomegaly. Okay, so again I'm going back to explain to understand these points. So Trobby space is nothing but a triangle space. So triangle bordered by sixth rib superiorly and left mid axillary line laterally and left costal margin inferiorly. So this is this space is nothing but triangular, shaded area is nothing but Trobby space. So sixth rib superiorly, left anterior axillary line laterally and inferiorly by costal margin, left costal margin. And what is Castell points? Castell point is nothing but in the last intercostal space, the point where last intercostal space and left anterior axillary line intersect, that point is nothing but Castell point. So the same thing you can see in this picture also, where see normally spleen is in the below the mid axillary line in and in case of enlarged, it crosses the mid-axillary line and come to the anterior axillary line. So in case of Castell points, if you percuss over that Castell point, in case of enlarged spleen, you feel dull note. And the pictures on the right side of screen, we show that Castell point, and another is the Nixon method. I am going to explain in the next slide Nixon method. So what is Nixon method? Nixon method is nothing but so in case of Trobis sign and in case of Castell point, patient is in supine position, but in case of Nixon method, patient should be placed on right lateral decubitus position and percuss at the midpoint of the left costal margin and proceed perpendicularly to the left posterior axillary line. So basically the points A, B and C, So this A to B is nothing but the left costal margin. So you take the midpoint of the left costal margin, that is the point C. Okay, from mid axillary line to Ziphoid process. So the mid-axial line, the coastal margin coastal margin in the mid-axillary line is the point A, and in case of the Ziphoid process, the point B. So you take the midpoint between A and B, that is C. So from that point, you percuss towards the mid-axillary line perpendicularly, 90 degrees. Okay. So percuss at the midpoint of the left costal margin and proceed perpendicular to the left posterior axillary line. Splenomegaly, if there is a dullness more than 8 centimeters. If you feel dullness for more than 8 centimeters, it is splenomegaly. Basically, all these methods are not done that much. Basically, for completion of the examination purpose, and you have to know, because these questions can be asked in viva or during examination. What is Nixon method, what is Castell's method, what is meant by Trobis space, what is bimanual method, and what is hooking method, what is Middleton manual. Okay, all these are for examination of the splenomegaly, for spleen enlargement. Okay, so going back again to know. So for in spleen examination, in case of inspection, palpation, bimanual method, hooking method, percussion, Probis sign, Castell sign, and Nixon method. Okay. So this is for kidney bimanual palpation. Ballot, you check for the ballotment. So the first picture shows the ballotment of the left kidney with two hands. You keep below the left posterior costal margin and another hand over top, and you fix one hand, and you basically we fix the superior hand, and from inferior we push up so that we can feel for the any surfaces and swellings and enlargement of the kidney basically. So this is a bimanual palpation where you check for the ballotment of the kidney, enlarged kidney. So both the right and left kidney enlargement, the pictures are shown. And coming to abdominal distension, about the fluid trill and other things. Basically, this today's topic I will be covering mostly on the hepatosplenomegaly part, but to complete the examination purpose, I have added the fluid trill and other things. Basically, you will be covered in, especially in the ascites of the clinical examination, clinical presentation, ascitic or nephrotic syndrome, where you will be seeing only the fluid trill and shifting dullness. But to know complete abdominal examination, I have kept it. You will be in next upcoming class you will be knowing what is fluid trill and again, but anyhow I will be telling you what is fluid trill. Basically, in case of fluid trill, patient in supine position and place the palm of your left hand against the left side of the abdomen, flick the finger against the right side of the abdomen. So ask the patient to put the edge of the hand in the middle of the abdomen, or you take some other support. Okay, so if the ripple is felt upon flicking, we call it as fluid trill. I hope you can see the picture. So shifting dullness. So basically, you can I think you can understand by seeing the shifting dullness. So basically, you will percuss over the abdomen, and the point where you come to the transition point where the dullness is coming, you will go to the lateral side percussing, and you ask the child to be shift to be in the right lateral decubitus or left lateral decubitus for 2 to 5 minutes and percuss again. So in case of right lateral decubitus, the fluid is shifted from the left quadrant to the right quadrant, and you feel tympanic now. Initially what you felt dull note, and now you feel resonant. This is called shifting dullness basically. And this is Patel sign, and you see the child is in the knee elbow position, and you have to wait for the 5 minutes. Basically this is done for very low amount of fluid to detect, basically around 50 ml of fluid, and you percuss from xiphisternum towards the umbilicus. If you feel the dull note, there is a Patel sign is positive, that is mild amount of fluid is present in the abdomen. So after percussion, we go for auscultation. So place the diaphragm of the stethoscope to the right of the umbilicus. So you have to see for the any aortic bruit or renal bruit, or in case of iliac region, and in case of uh, for bowel sounds. Okay, so bowel sounds, normally Borbergmi sounds causes peristaltic movements occurs every 5 to 10 seconds. So absence of bowel sounds indicate peritonitis, and bruits of the aorta and renal artery could be a sign of aneurysm or stenosis. And to complete the examination of the abdomen, you have to examine for the any hernial orifices and genitalia, and rectal examination. Basically we don't do rectal examination in children until unless it is required. So coming back to the causes of hepatomegaly, so there is a lot of causes, so many causes of hepatomegaly basically, but you can't remember so easily like that. So you have to basically remember in case of like either infections or inflammation, any storage and infiltration, and vascular congestion or biliary obstruction. So in these points, if you remember, it is good for you. In case of infections, you know, it is a malaria, typhoid and other things, and in case of inflammation, it can be because of hepatitis, autoimmune diseases, and toxins and drugs. In case of storage, it can be because of glycogen storage diseases, diabetes mellitus, and in case of lipid disorders, it can be Wolman's disease and Niemann-Pick disease. And in case of fatty acid oxidation defects, and in case of metals like copper, in case of Wilson disease, iron hematochromatosis, in case of abnormal protein storage like alpha 1 antitrypsin and carbohydrate glycoprotein deficiency, and in case of infiltration, it can be because of primary neoplastic tumors or non-neoplastic tumors like hemangioma, hemangioendothelioma, teratoma, focal nodular hyperplasia, and in case of cyst like parasitic cyst or choledochal cyst, and in case of extramedullary hematopoiesis, where you can see in beta thalassemia. Okay, and in case of vascular congestion, you can see like congestive heart failure, and Buchiari syndrome, and veno-occlusive disease. In case of biliary obstruction, cholelithiasis, choledochal cyst, biliary atresia. Okay, and splenomegaly. So going back to the causes of splenomegaly initially, so it can be because of portal hypertension, that is like cirrhosis, extrahepatic portal vein obstruction, congenital hepatic fibrosis, and Buchiari syndrome. In case of storage disorders, Niemann-Pick disease, Gaucher's, mucopolysaccharidosis. In case of hematological, it is leukemia, lymphoma, and in the initial part of the sickle, where spleen can be enlarged. and collagen vascular diseases and autoimmune hemolytic anemias, and in case of infections like malaria, enteric fever, viral hepatitis infection, mononucleosis, kala azar, mm, and extramedullary like osteopetrosis. So for grading of splenomegaly, we use Hackett's grading of splenomegaly. This is Hackett's grading. So grade 0 to grade 5 basically. Grade 0 is normal or not palpable spleen. So you cannot palpate the spleen. In case of grade 1, spleen palpable only on deep inspiration. That is uh, within the coastal margin region only. You can know it by hooking method or other methods only basically. And grade 2 is spleen palpable on mid clavicular line halfway between the umbilicus and coastal margin. So in the mid clavicular line, between the halfway between the in the midpoint of the umbilicus and the coastal margin, that is grade 2. And grade 3 is the spleen expanding towards the umbilicus and not reaching the umbilicus. Grade 4 is the spleen goes past the umbilicus, okay. And grade 5 is spleen expand towards the symphysis pubis or right iliac fossa. So basically grade 0 to grade 5, and you can divide the grading of splenomegaly into mild, moderate and severe, where you consider as till grade 2 it is called mild, and grade 3 is moderate, and grade 4 and 5 is massive, okay. Or else with centimeters, less than 3 centimeters is the mild, and 4 less than or equal to 3 centimeters is the mild, and 4 to 7 is the uh, moderate, and above 7 it be considered as massive splenomegaly. So this is important. The grading of splenomegaly is important based on Hackett's grading, and you have to know what is mild splenomegaly, moderate splenomegaly, and massive splenomegaly. And you have to know the causes of the mild splenomegaly, moderate splenomegaly, and massive splenomegaly. You have to go through the uh, clinical books again. So this is a summary. Basically, what I want to say is the summary of the abdominal examination, how it will be there. Basically, summary in case summary. So basically, in history. So what in history, what you want to ask whether the pain abdomen. In case of pain abdomen, what is the site? What is the radiation, timing, intensity, character of the pain? Okay. In case of presenting complaint is the bilious vomiting, suppose vomiting, whether bilious or non-bilious, what is the timing, what is the color, projectile or not. If the presenting complaint is constipation, what is the duration associated with bleeding or not. If it is diarrhea, what is the duration, frequency, association with blood or mucus, or any decreased urine output or normal urine output. And jaundice, any abdominal distension, no cause of abdominal distension, 5Fs, fluid, feces, flatus, fetus, feculates, okay. And bleeding, any bleeding from any site like uh, either melena or hematemesis, rectal bleeding. And in case of urinary complaints like dysuria, and what is the color, what is the output, increased output or decreased output, any alteration in appetite. And sorry for the mistake, that is scrotal swelling, uh, whether it is painful or painless. So in case of so history, that is the history. Case of examination, again it's just summary. Inspection, so you have to see the shape, abdominal movements, umbilicus, skin scars, and superficial veins, visible peristalsis, pulsations, and genitalia. So in case of palpation, superficial palpation or light palpation, and in case of deep palpation, you have to go for the organ enlargement like liver, right? What is the right lobe, left lobe? What is the size, surface, consistency, margins, tenderness, and any pulsations are seen or not. And spleen, based on spleen size, consistency, and splenic notch is palpable or not. Right kidney, left kidney, any enlargement, any cystic or urinary bladder, feculates, any other lumps. So based on any other swelling, what is the site, origin, size, shape, margin, surface, consistency, mobility, palatability, any signs of inflammation, impulse and coughing. Is there any abdominal wall edema and what is abdominal circumference using palpation. So in case of percussion, so any free fluid, puddle sign, shifting, dullness, and fluid thrill. Liver, upper, what is the upper border? In case of tidal percussion, you do tidal percussion and you will note the upper border and the total span of the liver. And spleen. Auscultation, you will check for the bowel sounds, renal bruit or aorta bruit over the aorta or venous hum. Mm. And in case of genitalia, hernial sites, check for the ambiguity, scrotum, and urethral opening. Is a normal or not. So this is how the summary examination points to be noted. Basically, you have to go through the history and in case of examination, inspection, palpation, percussion, auscultation, and genitalia. And we will go back to the case presentation one, and we will see and how we present the case basically. No, it's not over. Basically, we will go back to the case presentation. So this is a case presentation. A 8 years female child resident of Adilabad. So you have to know the age, gender, name. I have not kept the name because this is a virtual case presentation. Uh, so 8 year. So each and every point is important here. A 8-year female child resident of Adilabad brought by parents with presenting complaints of fever since 4 days. So presenting complaint is only fever. So what is the history of present illness? First thing, what is the presenting complaint, that you have to elaborate it, and later on you have to go with any positive history and any other negative history. So what is fever? Fever, how is the fever? Fever is a sudden onset, high grade, intermittent, associated with chills and rigors, and subsides with sweating. Okay, and there is no history of any skin rash. So the fever is not associated with any rash, so it's not looking like viral exanthem, and no history of cold, sore throat, cough, or dyspnea. So respiratory complaints are not there, and there is no history of vomiting, pain, abdomen, diarrhea, or melena. No history of burning, micturition, or hematuria. No history of bone pains, joint pains, sternal tenderness. No history of petechia or other bleeding manifestations. So most of the things here is pointing that there is no other system is involved most commonly. So we have to see for any anemia or any other things, and in case of anemia and other things, we have to go to the abdominal examination for any reticuloendothelial organ enlargement like spleen enlargement or other enlargement in case of other things. So past history, no history of similar complaints in the past, no history of any blood transfusions in the past. Family history, second in birth order, and sibling is 2 years elder and healthy, no history of TB in the family. So only presenting complaint is a fever. So antenatal history and postnatal history is uneventful, and birth history, female child, term gestation, normal vaginal delivery, cried immediately after birth, and no history of NICU admission. Developmental history, achieved milestones as per age and no developmental delay, studied in 4th standard. Immunization history, received vaccines till 5 years of age, BCG scar is present. And personal history, mixed diet, normal bowel and bladder habits, and not attend menarche. So 8 years not attend menarche, so we can wait. Nutritional history, pre-illness diet, no calorie and protein deficit, and socio-economic status belongs to lower middle class as per Kupaswamy scale. So general physical examination. So in case of general physical examination, so child is conscious, coherent, and oriented to time, place, and person. Coming back to anthropometry, the weight is normal, appropriate for age. That is 50th centile weight, height, and BMI is also 16 kg per meter square. Little bit underweight. BMI is 16, little bit low, but weight and height is in 50th centile. normal. Upper segment lower segment ratio is 1.1:1. Coming back to vitals, pulse is 101 per minute, regular, normal volume, no radial or radiofemoral delay. Temperature is 101 degrees Fahrenheit and respiratory rate is 18 per minute. And blood pressure is 100 by 70 mm of Hg, sumain in left hand. Okay. Coming back to head to toe examination, there is no facial dysmorphism and there is a pallor. So pallor is there. Okay. No cyanosis, no clubbing, no koilonachia, no edema, Tanner stage 2. Systemic examination. So basically, child is presenting with fever. So before coming to systemic examination, till now what we know is that child is having fever, that is high grade, intermittent, and associated with chills and rigors, and child is having pallor, basically. So we should know what we are thinking initially. So there is a involvement of rectal endothelial system. We have to think because child is having pallor, and you have to check for any organ enlargement is there or not. So for systemic examination, you have to go for periabdominal examination because respiratory system is normal basically, and no complaints from the respiratory system examination and CVS examination and genitourinary examination. Okay. So based on history, these three organs are not involved. So we have to go for perabdominal examination in case of this child because child is presenting with a fever and there is a clear-cut pallor in this child. So perabdomen. So based on inspection, what is the shape of the abdomen? Flat and symmetrical, umbilicus position, central, appearance, normal. There is no discharges and there. Movements, all quadrants are moving equally with respiration, no visible pulsation, visible pain, skin over the abdomen is normal, there is no scars and stray, hernial orifices are normal. Coming back to palpation, no local rise of temperature, soft abdomen, no tenderness, rigidity or hardening. And liver, based on liver is palpable 3 centimeters below the right costal margin, non-tender, smooth surface, soft in consistency, and regular margin. Okay. Spleen, palpable 3 centimeters midway between the left costal margin and umbilicus, soft in consistency and non-tender. So, palpable 3 centimeters midway between the left costal margin and umbilicus. So, it is coming into mild, basically. I said now before only that mild, moderate, and severe based on centimeters. Mild is nothing but less than or equal to 3 centimeters. Moderate is nothing but 4 to 7 centimeters, and massive is more than 7 centimeters. Okay, so splenomegaly is mild. Splenomegaly is there. Okay, palpable only 3 centimeters. Liver is also palpable. Percussion. So resonant all over the abdomen except liver and spleen, where dull note is that liver span is 12 centimeters. So basically it's increased. Normal it should be like for this skull it should be around 9 to 10. Auscultation, normal bowel sounds, no bruit, friction rub or venous hum. So what are the different methods of palpation of the spleen? So you have to know the examination of the spleen, different methods of palpation of the spleen, different methods of percussion, and different methods of examination of the spleen. Okay, so already we covered it by based on palpation, bimanual method, hooking method, and there is another thing, Middleton manual. In case of percussion, Proby space, CASTELL'S and Nixon method. Okay, so other system examinations to complete the things like respiratory system, no abnormality detected, CVS and CNS is also no abnormality detected. So this is a case summary. So 8 years female child resident of Adilabad brought by parents with complaints of fever since 4 days with abrupt onset, intermittent and associated with chills and rigors and subsides with sweating. On examination, child has pallor and belongs to Tanner stage 2. Per-abdominal examination shows hepatosplenomegaly. So nothing but you have to know the causes of the hepatosplenomegaly and that too associated with fever. Hepatomegaly with fever, hepatosplenomegaly with fever and all these things basically. Uh, so this is how the case summary is there and the case clinical case presentation of the GAT is completed and the other systems will be subsequently covered in classes and basically by listening to the class and going through the book doesn't you will not be get oriented to the how to take the case history and examination. Basically, you can watch the videos of the abdominal examination or other system examination. MacLeod's, there is a in YouTube you have the videos of MacLeod's. You can go through the each and every system examination has been presented. Uh, Videos have been presented. You can go through the videos of the MacLeod's examination videos in YouTube, and go through the Hutchinson book once. After seeing the video and read it once, so you will get to know what's there in the book, and you'll have good knowledge about the clinical case presentation and the things how you examine the uh, case, and what are the steps you need to do initially before inspection, before palpation, before percussion, and in each and every procedure. And the important thing is, before for each and everything you are going to do on a patient, you have to take the consent of the patient. That is very much important. So before touching the patient also, you have to take the consent, and you should initially start to talk with him and build a rapport with him, and ask for the patient whether he can examine or not, and show any painful areas are there or not, make him comfortable, feel good. These all things, bedside manners, are important in case of case presentation. uh, if any examiner asks for show me the spleen examination, how to do, don't go directly and palpate for the spleen from the right iliac fossa to the left hypochondrium region. Before that, ask the patient, talk with the patient, or if it's a child, you talk with the mother and make her feel comfortable, and tell her or tell the patient what you are doing, and make the patient comfortable, and help him to get into the position in which position you want to examine, and examine. Okay, all these bedside manners are important, which cannot be dealt in the virtual online teaching. But you can watch the videos of the MacLeod's, where you can see how the person interacts and everything. I hope you enjoy those videos, and anyhow, go through the Hutchinson clinical methods. And for pediatrics, you can go through any Meherban Singh or other clinical methods. Okay, thank you.